Good evening, everyone. Welcome again to another webinar in the series of webinars on HSG protocols. This is the second run after the one we had last year. Now, in this series, this is the fourth webinar. We are having 6 protocols of over 5 webinars on every Tuesday night. This is the fourth one. And today we are going to be doing 2 big topics, asthma and COPD. So the format will be similar to the previous webinars we had last year and earlier on in the series. There will be a presentation and a Q&A after that. You can start typing your questions into the chat and our resource panel will answer the questions as we go along. Our resource panel comprises the authors of the protocol, the members of the protocol subgroup, representatives from the Ministry of Health and AIC. So some questions we will take live where we have time. And after the Q&A, at the end of the webinar, there will be an MCQs, which will be released actually in 2 batches. The first batch was released last week. Second batch will be released after the last webinar next week. And for attendance in the webinar, you'll get 1 CME point. And you're encouraged to attempt the MCQs because you get another CME point. Now, last but not least, please, another reminder to complete the CMS Sutra survey because it's the last cycle and we hope to get a good response. Now, without much further ado, because we have a big number of topics, let's start straight away. To present COPD and asthma, we have Dr. David Tan from our College Council. David, please carry on.
Yep, a very good evening to everyone. Suraj, can hear me? Give me a thumbs up. Yeah, okay. Very good evening. Just as a quick introduction, my name is David. I'm a family physician currently working in one of the Western polyclinics. But this evening, I'm wearing my hat as one of the College of Family Physicians Council members, and I'm happy to bring to you the 2 new care protocols this evening on asthma and COPD. Like Suraj mentioned, it's 2 big topics crammed into one. So I think I'm going to take perhaps the full hour, but if you can bear with me, hopefully we'll have a good time of learning and sharing together. Again, just a reminder, please stay until the end of the webinar to qualify for your CME points. Please do your MCQs. The MCQs that we've set for these 2 care protocols are based really on the content that we'll be sharing, so you can find all your answers in tonight's webinar. Should be quite straightforward. Any questions that you might have, please feel free to type into the Q&A. Just as a refresher again, you can find all the care protocols on our college website, and you should be able to find the links here to all the previous videos that we've taken before, the MCQs, as well as the actual care protocols. On the care protocol page on primarycarepages.sg, you'll be able to find all the care protocols that we're going through, and asthma and COPD are at the bottom over there. So for this evening, some of our objectives that we hope to cover. Hopefully everyone at the end of this session will be familiar with the guidelines available for asthma and COPD, the diagnostic approach to these 2 conditions, be familiar with the stepwise management of asthma, as well as the management of COPD, and the healthier SG administrative requirements for asthma and COPD. A little bit of the scope that I'll be going through. I'm going to be covering some acronyms and definitions. I think asthma and COPD in particular, we tend to use a lot of acronyms, so hopefully we'll all be quite familiar with them. I'll be going through the background to each of these conditions individually, the clinical approach, management, as well as the care components. And if you could bear with me now, I'm just going to show a video to hopefully illustrate a little bit of the importance of one aspect of asthma and COPD. For some of you who may have seen this video before, bear with me. Okay, I hope that was an interesting video. So whenever we talk about asthma and inhalers, we almost always will refer to the house video on inhalers, which fails. One of the reasons I brought that up was because just a couple of weeks ago, I saw an asthmatic patient come into my polyclinic. He was having a persistent cough. I think we had been treating him with cough mixtures. It seemed to be related to his URTI. I saw him for the second time, I think just 1 or 2 weeks ago, and I decided to check his inhaler technique. And indeed, he had this similar inhaler that I'm holding in front of you. When I asked him to show it to me, this is what he did. He opened it up, turned it around like that, and gave himself. And that was exactly what he did. If you had observed that, could you just type into the chat perhaps some of the mistakes that I did and demonstrated with that way of inhaling? And let me continue to share my slides. Okay. We are going to see that actually inhaler technique is going to be a very important aspect of asthma management and COPD management as well. So hopefully, that video would have demonstrated a little bit of the importance. But as you guys are perhaps hopefully thinking of what I did wrong in that demonstration of the inhaler, I'm just going to carry on with the slides here as I go into the definitions and acronyms. GINA, GOLD, ACG, some definitions on exacerbations, a few more acronyms, ICS, LABA, LAMA, BDs, and just a little bit of definitions on preventers and relievers. Okay, for some of us who may be aware, GINA stands for the Global Initiative for Asthma. This is one of the international organizations that looks at asthma diagnosis and management across the world. GOLD stands for Global Initiative for Chronic Obstructive Lung Disease. You can find the websites for these two international organizations there. Both GINA and GOLD come out with regular guidelines almost every year to revise a little bit of asthma and COPD management and diagnosis. And over the past few years, we've seen quite a bit of change in terms of their classification and certain management principles behind it. For some of you, if it's a little bit new to you, don't be too worried. Our ACGs, which are our ACE clinical guidances, actually do cover quite a bit of that information in our own local guidelines. But of course, if some of you are going to be doing exams like the GDFM or the MMAT, it's good to know a little bit of what's going on with GINA and GOLD. On to a little bit more definitions. I've got the definitions of exacerbations here, and it's important to understand and remember what we mean by exacerbations, especially in asthma and COPD context. Okay, so for asthma, its exacerbations are defined as episodes characterized by progressive increase in symptoms, particularly of shortness of breath, cough, wheezing, or chest tightness. And you can find a little bit of decrease in lung function. And this is a change in the usual status that is sufficient to require a change in treatment. So basically, asthma exacerbation, progressive increase in symptoms requires a change in treatment. COPD exacerbations are defined as events characterized by increased dyspnea or cough and sputum that worsens in less than 14 days. And these two definitions are again from GINA and GOLD guidelines. So again, good to be aware of these definitions, and I'll be referring to them later on as I go on to the rest of the slides. Okay, and going on, ICS is a very common acronym that we use for inhaled corticosteroids. So you're going to be hearing me refer to ICS quite often, whether ICS alone or ICS in combination with other medications like LABA, right? And examples of inhaled corticosteroids or ICS would be beclomethasone, budesonide, which you can find in Pulmicort or Symbicort, and fluticasone, which you can find in Flixotide or Seretide. I like this chart that you can actually find in the ACG on asthma, right? And here, what I'm demonstrating here are the different common ICS that we may find available here in Singapore. Beclomethasone and budesonide. I've mentioned fluticasone, I've mentioned there as well. And what's useful to pick up from this slide is not just the inhalers or the inhaler names, but particularly the daily dose of these steroids, whether they're classified as low, medium, or high. Yeah, particularly because in a condition like asthma, when I'm going to be talking about stepping up treatment for patients with asthma, we're going to be looking at whether a patient is, whether a patient is on a low daily dose of ICS. And if you need to step up treatment, you might want to step up to a medium. And what's important about that, for example, beclometasone. Many of us are familiar with the 50 micrograms per actuation, beclometasone. So if you consider a patient who's taking 2 puffs of beclometasone, 50 micrograms twice daily, that adds up to about 200 micrograms. So for an adult, if you can look at the upper left corner, more than 12 years old, 200 micrograms still puts this patient in a low daily dose of ICS. So if you need to step up treatment, increasing that inhaler by 1 more puff in the morning and 1 more puff in the evening, 3-3, is not going to put him to a medium kind of daily dose setting. So you would have to increase the number of actuations a lot more than that. So knowing this chart is helpful in helping to guide us in terms of treatment for our patients. A little bit more definitions and acronyms. LABA, like for earlier mentioned, LABA stands for long-acting beta-2 adrenergic agonist. And examples of that would be salmeterol, which you can find in a medication like Seretide, or formoterol, which you can find in some of the formoterol-containing medications such as Symbicort. LAMAs would stand for long-acting muscarinic antagonist. And examples of these would be tiotropium, which you can find in the medication Spiriva, or umeclidinium, which is one of our highly subsidized LAMA inhalers, which you'll be able to find in Incruse. BD, I would refer to as bronchodilators. And again, bronchodilators, you may have your short-acting bronchodilators or your long-acting bronchodilators, like the LABAs and LAMAs. Important for us to, again, just refresh that definition of preventers and relievers, often used in the context of asthma again. Preventers refer to medications which target both domains of asthma control, which are symptom control and future risk, and relievers, which are asthma inhalers, which are taken as needed, often for quick relief of asthma symptoms. Okay, so having covered a little bit of the definitions, I'm just going to jump straight into the condition, and I'm going to be starting off with asthma here. So asthma, I think we all know, is a chronic respiratory condition, but I emphasize the word chronic here, right? Because as much as we may understand that asthma is a chronic respiratory condition, often asthma gets treated as an acute kind of situation where sometimes we may treat the patients when they come in with an exacerbation, but once they resolve, we don't quite have a regular follow-up with them. So similar to how we would treat other chronic conditions such as diabetes, hypertension, or hyperlipidemia, it is important to recognize that asthma is similarly chronic in nature. We have to give our patients regular follow-ups, regular reviews, and if patients default treatment or follow-up, we have to have a system to call them back. In asthma, we do know that hospital admissions are largely avoidable, and often patients do end up being admitted to hospital because of poorly controlled asthma or resulting in an asthma exacerbation. We do know that the economic burden of asthma is high, and often it is largely attributed to poorly controlled asthma. Credit goes to the SNAP program for this very nice infographic here. For some of us who might not be aware, SNAP stands for the Singapore National Asthma Program. This is a program held under MOH in the primary care division, where we have a program looking after asthma, particularly in primary care. And this infographic that's come out is quite informative and hopefully enlightening for many of us in the audience today. From the graphic, we can see that the lifetime prevalence of asthma is not low. About 10% do get diagnosed with lifetime asthma. And for children, it can be as much as 20%. And for adults, the prevalence does go down a little bit, but still significant enough at 5% of adults with asthma. On the upper right, we can see that people with asthma, about 1 in 3 have reported asthma attacks in the past year. It is not rare, and therefore it is important for us to be aware of that. For people with asthma, 1 in 2 do report missing school or work, and that also adds on to the economic burden that asthma might have on our population. Looking in the middle, only about 26% of people with asthma have used their preventer inhalers in the past month, which is way too low. While we say that ICS or inhaled corticosteroids are the foundation of treatment of asthma, only 26% are using their preventers regularly. And up to about 17% of patients with asthma have no regular follow-up. Again, highlighting the importance of us recognizing asthma to be a chronic condition and the need to give our patients regular appointments with our practices. So I've divided the clinical approach into what we can do to suspect asthma in new patients, as well as what to do for known patients. So for new patients, we should start to suspect whether a patient might have asthma when they present with suspected features. Of course, if a patient presents with wheeze, often it will be quite much in our minds about whether this patient might have asthma or not. Shortness of breath or chest tightness often happens together as well, and many of us might be prompted towards that. The reason I've highlighted cough there is because some patients may not always present with a wheeze or chest tightness, they may just present with a persistent cough. So rather than treating them with cough mixtures or cough tablets or lozenges, we should consider asthma if perhaps they keep presenting with persistent cough, especially cough which happens at night. And then we might want to dig in a little bit into the history to see whether they've got other supporting features of asthma, such as other history of atopy, allergic rhinitis, allergic conjunctivitis, eczema, or even a family history of such conditions as well. If we do suspect asthma in such patients, we may want to consider tests to measure their expiratory airflow limitation. And this would include tests like spirometry tests or peak expiratory flow if you have access to a peak expiratory flow meter. Do consider about whether they might be on medications that can cause bronchospasm. Some of the common medications that we might give in our practice would be things like beta blockers, like atenolol, aspirin or NSAIDs. You could be giving NSAIDs to someone with pain, persistent knee pain or pains and all that, and you could be triggering off a little bit of bronchospasm in someone who's susceptible. ACE inhibitors are also very commonly given, especially with many people having hypertension or even chronic kidney disease. The last two are probably less commonly used in our setting, but again, do consider whether a patient presenting with asthma symptoms might be on any of these medications. Apart from looking at medications, as we assess new patients with possible features of asthma, it's always important to exclude differentials as well. So things such as cardiac causes, whether a patient might have congestive cardiac failure, whether there could be a GI cause of the patient's symptoms. Commonly, reflux can cause a little bit of persistent cough, even nighttime cough as well, and other respiratory or infective causes. And then we might want to consider whether or not a patient might benefit from bronchodilator reversibility testing, which some of our labs which do spirometry tests can do. For patients who are known to have asthma, then we should be assessing their asthma control on a regular basis. And here I've put two possible tests of asthma control, GINA and ACT. I think many of us might be familiar more with the ACT, the asthma control test, which we have been using for many years. But now GINA is one of the other tools that we can consider using to assess a patient for asthma control. And this is a brief of the GINA symptom control tool. It is quite short and quite straightforward to use. And you can see that from these 4 questions, what we should be targeting is that a patient should answer no to all of these questions, indicating that they have well-controlled asthma. The moment a patient says yes to any of these questions, they are already not well-controlled, and they would be either partly controlled, or worse, if they answer yes to 3 or more of these questions, we'll consider them to have uncontrolled asthma. And definitely we will need to optimize their asthma control. Do note the point at the bottom that for Healthier SG, submission of the GINA score is required for subsidy claims and Healthier SG payments. So we're no longer going to be using ACT as a way of measuring symptom control, but more the GINA scores. And many of you would have had this inbuilt into your CMS systems already. In many of our polyclinics, we have also shifted over to using GINA score as a way of assessing a patient's symptom control. So assess asthma control for known patients, assess their future risk as well. And what are some of the future risks for asthma exacerbations and poor outcomes? Quite a long list here, but quite intuitive. Yeah, obviously, if a patient has had one or more exacerbations in the previous year, you might want to be a little bit more cautious with this patient. If they've had any history of intubations or admission to ICU because of asthma, we got to keep an eye on this patient to make sure that their asthma is well controlled. Patients who are on SABA-only treatment, short-acting beta-2 agonists, if they're only using their salbutamol only without any ICS, they would be at high risk of having future asthma exacerbations and poor asthma outcomes. And beyond just relying on SABAs alone, if they're overusing your SABAs, finishing, for example, one or more canister of SABAs in less than 2 months, one canister of SABA should have 1 to 200 actuations. So for them to finish this in less than 2 months, that's really using it a lot. And you can imagine relating that back to the GINA symptom control, they would definitely be in the uncontrolled range. If they're not adherent to preventer therapy, poor technique, as what I demonstrated earlier, if they have exposures to triggers such as smoking, a poor lung function by measuring their FEV1, or they have socioeconomic problems, all this would put them at risk of poor asthma outcomes. Beyond just looking at assessing future risk, then we would want to optimize asthma control. Again, recognizing ICS as foundation of treatment, and I will touch upon this in the management slides. Look out for any modifiable risk factors, such as allergic rhinitis, obesity, gastroesophageal reflux, because we do know that these risk factors are related to asthma exacerbations as well. Of course, smoking is going to be one important thing that we have to assess our patients for. And if you do find that your patients are smoking, do consider referring them for a smoking cessation program. And we do have a care protocol on smoking cessation, so all the information is available there for you. Of course, they would benefit from vaccinations because this would protect them from any respiratory infections, so namely influenza, pneumococcal vaccinations, and of course, self-management. This slide is a nice slide demonstrating how we can educate our patients on self-management. This is an example of a written asthma action plan, or WAAP for short, or some of us like to call it a WAP. What this WAP is demonstrating is the action plan for someone who is on beclomethasone, 50 micrograms, 1 puff twice a day. I have put this off my own polyclinic's intranet, but I think many of you may have access to this in your own PCNs or in your own clusters. If you don't ask your PCN coordinators, I'm sure they can help you get your hands on templates which help to auto-populate the different areas of this written asthma action plan. If you are able to follow my mouse, what this action plan is meant to do is to inform and educate patients what to do if they are not in a green zone, if they start having certain problems, for example, waking up at night due to asthma symptoms, having daytime symptoms more than twice a week, using their relievers more often than normal. If such a situation were to happen, then they are meant to step up their preventer treatment. Here, it's auto-populated in this WAP that the patient should be stepping up their beclomethasone from 1 puff twice a day to 4 puffs twice a day. So that's a quadruple increase in the dose. They can also start using their relievers, salbutamol on a regular basis, 2 puffs 3 to 4 times a day, and they can consider starting their dose of prednisolone once they're in this yellow zone and they're not getting better despite increasing their inhalers. Of course, if they're not getting better, this WAP is also meant to advise them to seek medical attention, whether by going to your clinic to get help or to call for an ambulance to be brought to the hospital. So having spoken about the clinical approach, now we are going into management. So like I mentioned, asthma management stepwise approach. And this is a very nice graphic from our own local guidelines, the ACGs on asthma management. What you can see are the different steps that a patient might be on. And if you look at the upper row, which are the patients more than 12 years old, you can look at the different preventer options that the patient is on. Having gone through the GINA assessment of symptom control, we can decide then whether a patient is well controlled, or perhaps they are not so well controlled, or they are uncontrolled. And if you do find that the patient is not controlled in terms of their asthma, that is when we have to step up their medications then in order to get their condition under control. So imagine if you had a patient who was on low dose ICS. And low dose, if you remember the chart that I had shown earlier on, if they're on a low daily dose of ICS and you find that they're not controlled, that is when you should step up the patient to the next step. And in this case, you would go on to step 3, where you might put the patient on a medium dose of that ICS that the patient is on. Or if you find that the patient is not optimized on that, you could consider giving a ICS-LABA combination. And this is how I would use this graphic here to help to guide me how to step up a patient depending on what step they are on for their treatment, or even step down a patient if they have been well controlled on their inhalers for a sufficient duration of time. I had included this graphic from the GINA guidelines just to inform everyone that this is what it looks like. It does look a little bit different from what we have locally, just for everyone's information. GINA does tend to prioritize a preferred controller and reliever. Just for some of us, I think we might be aware that ICS formoterol containing medication can be used as a single maintenance and reliever therapy. And this is what GINA has stated in their own guidelines. On track 2 at the bottom there, you can see that this is quite similar to what we have locally, that there is that recommendation for using ICS whenever a SABA is taken, or stepping up to a low dose maintenance ICS when needed. And this is quite similar to what we have in our local ACG guidelines. What I like about the GINA guidelines as well is that it does give you the different symptoms, different steps for which you might want to initiate treatment for a patient depending on their frequency of symptoms, right? And this is quite clearly spelled out in the GINA guidelines as well. So do get your hands on these inhaler charts if you're able to. I think if you have any issues getting them, you can always contact your PCNs or your seniors in your clinic, or you can even approach any of us within the care protocol group. So I've spoken a little bit about stepwise approach. I think just some things to highlight here. Oral salbutamol shouldn't be used. I've spoken a lot about inhaler medications, and inhaler therapy is the way to go for respiratory conditions such as asthma and COPD, because it delivers the medication directly into the lungs where the patients need it. Now, oral salbutamol, whether it's in a tablet or syrup form, is just going to cause a little bit more systemic side effects, and it doesn't often help to control the patient's condition. I did mention about SABA monotherapy, but I think we cannot repeat it enough again. We should not use SABA monotherapy, especially in patients 6 years old or more. ICS should be the foundation of asthma therapy in such patients. Be cautious, be very cautious about SABA overuse. So even in some of our patients who may seem to be taking ICS on a regular basis, do be careful, because some of them might come to our practices often just to obtain more of their SABA inhalers. And they may not tell you that they're not using the ICS, but they may be relying more on their SABAs for symptom control. Technique, again, is something that it is good to assess our patients for, because if they're not having a good inhaler technique, the medication is not going to go in where it's supposed to. And oral corticosteroids, what I've mentioned, can be used for exacerbations. They should not be meant, they are not meant for regular use. And again, our ACE clinical guidelines have all this information available. So do look at the ACE websites. On primary care pages, you will be able to see all these different resources available as well. Just a little bit about self-management in asthma. The WAP, the Written Asthma Action Plan, is something that I've gone through. Do assess your patients for inhaler technique, and you can consider teaching your patients a little bit about self-monitoring. Again, if you need to see any of the inhaler videos to teach your patients, or even to refresh your own memory about how to use inhalers, all these are available on the ACE web pages. I won't spend too much time on this. You can find this bit about self-monitoring on the care protocols, the asthma care protocols. We don't often have access to peak expiratory flow meters, but if you do, and if your patients are empowered enough and educated enough to self-monitor, this may be something that you can consider for them, teaching them how to determine their own best peak flows, what's their regular peak flows, and you can even maintain a diary, similar to how our patients may maintain a blood pressure diary, and determine when they're not better. if they are getting a little bit of a cough or URTI, you can teach them how to use the peak flow to determine that, hey, perhaps their asthma is getting a little bit worse, and that may be a good time to step up their asthma treatment. I want to give credit to maybe our PCN nurses for providing some of these slides here. And I'm just going to talk you through this slide just to show the value that our colleagues in the PCNs or even our polyclinics can bring to us. So this case was about Madam S here, who was the mother of a patient that this GP was attending to. So when they were sent for counseling, Madam S told her PCN nurse counselor that she had stopped administering the inhaled medication for her son because, and she was afraid of telling the doctor the truth, scared the doctor would scold her. The nurse reassured her and explained that, unless the doctor understood the reason for non-adherence, the son's condition could worsen. And the mom shared an incident, her son had seen a lizard in the room and playfully used the inhaled medication to spray over the lizard. And the lizard apparently died shortly after. Whether it's because of the medication or not, we can't be too sure. But because of that incident, the patient's mom, Madam S, then strongly believed that the inhaler contained harmful medication. Realizing the misconception and the knowledge gap, the nurse then explained how the medication in the inhaler worked and reinforced the importance of adherence to the prescribed treatment plan. So obviously they had a good laugh about it. But after this incident, the nurse informed the doctor of the conversation, and because of that, the doctor was aware of what had transpired, and he was able to reinforce the treatment plan to Madam S and the son. And this does show that strong partnership between the nurse and the GP in a team-based care approach does lead to better outcomes for the patient. So please do consider tapping on your PCN nurses or your nurses within your practice to help to counsel patients. Apart from checking on the inhaler technique, there's much that they can do in terms of addressing certain misconceptions that our patients may have. Just a few points beyond pharmacological management. Of course, smoking cessation is going to be very important. So if you do find that your patients who have asthma do smoke, again, tap on the smoking cessation resources. Or if your patients are exposed to secondhand smoke, consider how you can help them with this issue. And again, preventive care, vaccinations, I've spoke about that. Haze is something that, touch wood, we hopefully we won't see again this year, but it comes every now once in a while. And when we do expect a haze situation to come about, we often do receive advisories and circulars from MOH. So when you do receive that, please think about your asthma patients who might need a little bit of reminders to be more regular with their preventive medications, their ICS, and you may want to call them back for a little bit more regular monitoring. Most of the times, asthma should be well managed in our own primary care setting, but we might consider referring a patient to the specialist if we have difficulty with diagnosis. If you suspect the patient having occupational asthma, and this is when an occupational physician might come in, or a respiratory physician. If the patients have uncontrolled asthma despite already being on medium to high daily doses of ICS, if they are experiencing side effects of medications, if they have any of the asthma subtypes, such as eosinophilic asthma, things like that, then you may want to consider referring, or specific patient groups, such as those who are pregnant or high-performing athletes, for example. And my last few slides on asthma, I'm going to be just talking briefly about asthma exacerbations. Like mentioned earlier on, exacerbations reflect a loss of asthma control. And like earlier defined, it is an increase in symptoms which requires an increase in treatment. And we do know that the underlying pathophysiology is because of an inflammatory response that's going on. And the thing is, this inflammatory response can go up to 2 weeks, during which the patient may have risk of further exacerbations, which is why during an asthma exacerbation, apart from treating the patient in your clinic, it may be time to start an ICS if the patient is not already on a regular ICS, or it is time to step up the ICS, doubling or quadrupling the dose where possible, and giving the patient a short course of oral corticosteroids to help to manage this inflammatory response. And it's important to follow up the patient in about 1 to 2 weeks' time to make sure that the patient is getting better and not worsening, not requiring escalation of treatment. Again, you can find all of this in the asthma care protocols. I think suffice to say that for patients with mild to moderate asthma exacerbations, you can treat them in your clinic with inhaled SABA, and many of us in the polyclinics have moved away from nebulization. We give our medication with an MPI plus a spacer, and you can give 4 to 10 puffs, and you can repeat this every 20 minutes for 1 hour. You can give a stat dose of oral prednisolone, and you monitor the patients. Of course, if they're better, you can send them back home. But if they're not, then you may want to consider sending them to the ED. I included here my own clinic's protocol for acute exacerbations. And again, I think this is a useful resource to have. So you can talk to your PCN HQs about getting a protocol like that you can easily refer to, just in case you have a patient that you need to manage who's having an asthma exacerbation. The last few slides are just on care components in asthma. We spoke about assessing a patient's asthma control, and this is now with the GINA symptom control score, and this should be submitted twice a year. You should be assessing your patients for smoking at least once a year, and try to educate your patients. Of course, if you diagnose a patient with asthma, that's when the self-management education should come in. And whenever there's a change in medication, that's when it'll be a good time to give the patient a written asthma action plan so that they know what to do in case their asthma gets a little bit worse or they happen to fall sick. Spirometries are not compulsory, but if clinically indicated. Ask your PCNs if you're not sure about how to get access to spirometry services, and spirometry services sometimes can be useful in assessing patients with suspected asthma. Of course, the vaccinations, like what I mentioned, so influenza vaccinations per season, and pneumococcal vaccinations, and of course, COVID vaccinations as per the ongoing recommendations. That's for asthma, and I'm just going to move on to COPD. I'm just going to take a quick sip. Suraj, do we have any burning questions that we might want to answer for asthma so far?
So far, I think we can. No, the questions have been answered by typing on the chat. So I think we just quickly push on with COPD, then we see whether there are any questions at the end of it. But
okay,
I know we'll type in the answers as we go along, right?
Okay, so thank you. Thanks for hanging with me thus far. Let's push on. We've got one more condition to cover, COPD. But again, feel free to type your questions in the Q&A section. And I think my friendly team of question answers will strive to answer your questions. Okay, so on to COPD. Similarly, we'll be covering a little bit of the background, clinical approach, management, care components to COPD. So again, to rehash, COPD, similar to asthma, is a chronic respiratory condition. So again, do consider COPD as a chronic condition similar to our other chronic diseases. Patients should be given a regular follow-up. I think the key symptoms here that we talk about for COPD would be the three main ones of shortness of breath or dyspnea, cough, and sputum production. And often COPD can be associated with things like exacerbations as well. COPD differs a little bit from asthma in that the symptoms may tend to be persistent and often progressively worse, particularly if the cause of the COPD isn't settled. And often we know in the context locally and internationally as well, COPD related to smoking. If the patients don't stop smoking, the symptoms will be persistent and then progressive, and you get worsening airflow obstruction. We do find that locally, COPD tends to be underdiagnosed, could be because of the lack of clinical suspicion. We do find that one issue is often the underuse of spirometry. So later on, we can discuss about how you can get access to spirometry in order to be able to diagnose your patients a little bit better. In some studies, we've shown that COPD can be overdiagnosed as well. So patients that we suspect to have COPD just because they smoke, they come in with a cough, persistent sputum, we diagnose them with COPD, we give them some of the inhalers, but we may be over-treating them. Again, it could be related to the lack of use of spirometry. So I think here is where we can't overemphasize the importance of spirometry in assessing a patient presenting initially with what could be COPD. Do take a good history, smoking history, PET years, do your physical examination. And again, the spirometry is quite important there in order to clinch your diagnosis of COPD. So new and known patients again. For new patients, again, similar to asthma, we may be prompted to think about COPD when patients present with often a persistent history of symptoms and exposure. Exposure in our context, again, exposure to smoking, although we do recognize that some patients may not have had a significant smoking history, but perhaps exposure to outdoor or occupational sources, indoor solid fuel exposure, less commonly in our setting, genetic conditions, right? So look out for that history. And if they have symptoms, persistent symptoms of dyspnea, wheezing, and particularly chronic cough, do think about COPD in this group of patients, for which we might need to order a spirometry. And again, that spirometry to confirm the diagnosis. This is my only slide where I have spirometry values here. The main values that we'll be looking out for would be the FEV1, FVC ratio of less than 0.7 or less than the lower limit of normal. I think in order to build up your own confidence in spirometry reading, you may consider attending one of the spirometry workshops that the college organizes time to time, as well as the workshops that your PCNs might have available for you. So do look out for those. When we are assessing new patients for possible COPD, a chest X-ray is often useful as well, because in the initial presentation, we want to rule out other diagnoses at presentation, the common diagnosis of cardiac conditions, other lung infections. This would be useful in the initial assessment of someone presenting with what could be COPD. And do consider referring these patients if there's any diagnostic uncertainty. We do know that COPD tends to happen in the older age groups. So if you have someone who's presenting at a young age, for example, less than 40 years of age, or if they have low or no exposure to anything that could have caused the lung damage, like smoking, or if they have symptoms that could be asthma or COPD or both. Yeah, and now we talk about asthma plus COPD, then you might want to refer these patients on to a respiratory physician for further assessment. For known cases, if you happen to see a COPD case who perhaps you have taken over the care of from another GP or has been discharged to you from a specialist in whatever setting, confirm if this diagnosis was done with a post-bronchodilator spirometry. Because of what we've earlier discussed, some patients may be overdiagnosed, for example, right? So if a spirometry has never been done before, you can consider performing a spirometry for this patient in order to make sure that the diagnosis is correct. And beyond doing that, we should be assessing their symptoms and exacerbations. And this is where we talk about the CAT, the COPD assessment test. This is quite a straightforward test consisting of 8 questions here. It's scored quite objectively from 0 to 5. And as you can see at the bottom here, the submission of the CAT score is required for all subsidy claims and healthier SG payments, similar to the GINA score being required for asthma. I did mention earlier on about this MMRC. The Modified MRC Medical Research Council Dyspnea Scale is another way of assessing patients for symptoms, but this is not what we're using for submissions locally. I think it's just for us to be aware of it, just in case you hear people mention using MMRC to assess for patient symptoms. But the CAT, the COPD assessment test, should be the one that we're using. This is the one that our nurses are using to support us in assessing our patients for symptoms of COPD. Beyond assessing symptoms, exacerbations, smoking cessation, obviously, for our patients with COPD, optimize their control with regular use of inhaled bronchodilators. So a little bit of a difference from asthma, where ICS is the foundation of asthma therapy. For COPD patients, it should be the regular use of inhaled bronchodilators. Treat whatever modifiable risk factors you can find. So again, if patients are smoking, if they've got other comorbidities, we would want to treat those as well. Vaccinations, self-management education skills, physical exercise is important, and many of our patients will listen to our advice. So getting up and about to maintain their muscle mass to prevent sarcopenia, and giving patients regular reviews. The goals of management of COPD are really to reduce symptoms and reduce risk. And we can do much in terms of these two areas here. Relieving the symptoms, we can help by giving the regular bronchodilators, advising on exercise to improve their exercise tolerance, to prevent their disease progression, treat exacerbations. That's where our vaccinations come in, and therapy whenever patients present with what could be a COPD exacerbation. Regular reviews, I've mentioned as before, and again to emphasize, COPD is a chronic disease, so do get your patients a regular follow-up, similar to how we would follow up our patients with any other chronic disease. Assess their symptoms using the CAT scores, encourage adherence to treatment, and screen for their exacerbation history in the past 12 months. Pharmacotherapy for COPD is very much based on their symptoms and risk, and this is where our ACG on COPD is quite clear in terms of the treatment and management of COPD with pharmacotherapy. Going from the top, assessing patients for the number of exacerbations in the last 12 months. If they have one or less exacerbations, then we can determine based on their symptoms. If they're not so symptomatic with a CAT less than 10, you can just give them a LAMA alone. If they have one or less exacerbations in the past year, but are a little bit more symptomatic, that is when we may consider giving them a LAMA plus LABA combination. On the other hand, if assessing the patient, they have a lot of exacerbations, they've had 2 or more exacerbations in the past year, or they had 1 exacerbation or more leading to a hospitalization, you may want to consider giving them a LAMA-LABA already at the outset. But if we can assess them for the need for inhaled corticosteroids, a simple full blood count would help to reveal if their blood eosinophils are more than 300 cells per microliter. If you have patients with high eosinophils counts, this is when you can consider a triple therapy, such as a LAMA, LABA plus ICS combination. Right. I think this diagram is quite straightforward. And again, this is something that you can keep easily accessible so that this can help you in your management of your COPD patient. Again, just to highlight what's available in the GOLD guidelines, right? Because I think many of us are also informed by what GOLD is doing. GOLD tends to split it up, the treatment between initial pharmacological treatment and subsequent treatment. Yeah, so some of you might have heard of this ABCD and recently changed to the ABE grouping for COPD management under the GOLD guidelines. So what GOLD does is to assess patients based on the number of exacerbations that they might have. Yeah, so if they have 1 or less exacerbations, they would belong in the bottom category. And depending on whether they are symptomatic or not, if they are less symptomatic, CAT score of less than 10, they would belong in group A. If they are a little bit more symptomatic, they would belong in group B. And that's where the LABA-LAMA combination might come in. Of course, if they have more than 2 or more exacerbations or 1 leading to hospitalization, you would want to give them a LABA-LAMA combination and considering the addition of the inhaled corticosteroid if their blood eosinophils are more than 300. And follow-up of pharmacological treatment, what GOLD suggests is to assess them for their symptoms, whether they're having more dyspnea symptoms or whether they're having more exacerbations. It may seem a little bit confusing, so you can take a little bit of time to digest this on your own, but suffice to say, our ACG actually does a pretty good job in terms of differentiating this. So I think this would be something that we can refer to and can help us in our management of our patients. Okay, so just to state, long-acting bronchodilators are preferred over short-acting. So you can see whether it's the GOLD guidelines or our ACGs on COPD, they do suggest using a long-acting bronchodilator. So whether it's a LAMA or LAMA-LABA combination. Short-acting bronchodilators may be used, and actually many of our patients may actually be on a PRN short-acting bronchodilator. By recognizing the guidelines now, actually, if we can convert them to a long-acting in order to give them better control of their conditions. Do take note that if a patient is already on a LAMA, a long-acting muscarinic antagonist, don't give a short-acting one because you could increase the risk of anti-muscarinic side effects, right? ICS, like mentioned earlier on, has a limited role in COPD management. very unlike asthma. So monotherapy with ICS is not recommended. Studies have shown that does increase the risk of pneumonias. If you're going to be giving an ICS, it should be given as part of triple therapy for that group E of patients, or patients with a lot of exacerbations and you have assessed to have blood eosinophils which are high. Mucolytics like Flumasil, Mucosolvan, they can be used as adjuncts to inhaled therapy. So again, the foundation should be your inhaled long-acting bronchodilators. Smoking cessation, again, is important as management. That's where our smoking cessation clinics come in. Our nurses can come in to help to counsel our patients on smoking cessation, physical activity, and you may even consider pulmonary rehabilitation if you have access, or you can refer patients who are suitable for that. COPD education, our nurses come in very, very importantly, and preventive care, like mentioned. Another case that I think our AIC nurses have helped to bring up, this was a case of Bruce, who is a 55-year-old chap who was sent to see a nurse counselor to check about his medication adherence and inhaler technique. And during the nurse session, the PCN nurse inquired about his adherence, and he was able to describe the details of his medication, and we were satisfied. And the nurse helped to reinforce the recommendations on the frequency of the use of the inhaler. But when the nurse assessed how Bruce used his inhaler, she noticed the incorrect inhaler technique. She saw that most of the medication was actually escaping from his mouth because of poor coordination, and as such, he was not able to inhale the medication effectively. So she told the patient that it would be important to share the findings with the doctor, who then prescribed the spacer to help to improve the medication delivery. So with the aid of the spacer, this patient was able to fully inhale the medication and expressed great satisfaction and relief from his symptoms. So this case, I think, highlights the importance of having the nurse, again, as part of that team, to be able to get the patient to adhere to the prescribed preventers. And again, the communication between the nurse and the GP does help to improve the patient's condition and control. Okay, so when do we review patients? As mentioned, COPD is a chronic condition. For regular patients, we can see them every 3 to 6 months. But if you have a COPD patient who just had an exacerbation, you would want to follow up the patient within 1 to 2 weeks, similar to how you would follow up an asthma patient with a recent exacerbation. If you're going to be starting or adjusting treatment, you would want to follow up the patient within about 1 to 3 months in order to assess the patient's response to the treatment that you've given. We might consider referring such patients to the specialist if there's any difficulty with diagnosis and management. Like earlier mentioned, if you suspect the patient has features of both asthma and COPD, the patient is very young, or perhaps you're not quite sure about the diagnosis, we can get our specialist colleagues involved. If the symptoms are disproportionate to the FEV1, the lung function of the patient, for example, having very, very bad symptoms despite having a good lung function, if the patient has frequent infections and exacerbations, new signs appearing like hemoptysis, cyanosis, edema, or you think the patient needs long-term oxygen therapy, that's a good time to get our specialist colleagues involved. And my last bit here on exacerbations for patients, similar to asthma, exacerbations again in COPD patients is when symptoms and signs are getting worse over a short period of time. Again, patients with severe exacerbations should be transferred to the emergency department. What we can do is to consider treating the patient while waiting for an ambulance to come if the patient is deemed to have a severe exacerbation. What are the signs you'll be looking out for to determine whether the patient has an exacerbation? Your 3 things again, right? Your dyspnea, sputum, purulence. So there's a patient having increasing dyspnea, increasing volume of sputum, and increasing purulence of sputum. And they may also present with an increased cough or wheeze. Of course, we would want to consider other differentials as we are assessing a patient with an exacerbation, because these patients are also at risk of having heart conditions like an acute coronary syndrome. It could be at risk of having a pneumonia, pleural effusion or pulmonary embolism, or heart failure. And that's where our history and good physical examination comes in to help to differentiate. Again, our care protocols has very useful information on how to treat our patients with an exacerbation, you can give an MDI and spacer, or you can consider giving nebulized salbutamol, ipratropium, and normal saline. We would prefer air-driven nebulization if you're going to be nebulizing the patient to avoid the risk of respiratory failure, and monitor these patients closely in your clinic. Consider a course of initiating the corticosteroids orally, and you might want to consider oral antibiotics if there's any signs of bacterial infection. If the patient has very low SpO2 or a reduction of more than 3% from the baseline SpO2, if you know what the baseline SpO2 is, you can consider administering controlled oxygen therapy at a very low flow, and of course reassessing the patient after bronchodilator therapy has been given. Again, here I've included the workflow for my clinic. Try to get your hands on one for your own clinic so that you have quick access to what you can do for a patient having an exacerbation. We will consider referring these patients to the ED if they have severe signs and symptoms, they're confused, hemodynamically unstable, they have insufficient home support, and they are failing to respond, right? And these are the situations that we'll consider referring the patients to the emergency department. For the patients who are having a mild to moderate exacerbation, we can consider outpatient follow-up, give them their SABAs, the short-actings as needed. Do start the regular long-acting bronchodilators if they've not already been on it. And you can consider giving them antibiotics if they have 2 or more of this increased dyspnea or increased sputum volume or increased sputum purulence, and get the patients back in 1 to 2 weeks. Last few slides on the care components. Similar to asthma, we have our regular things that we should be submitting for COPD. Weight and BMI annually, the CAT score annually as well. Do assess your patients for smoking, self-management whenever you can, and of course that's where our nurses can come in again as a big assistance to us. Spirometry, like I mentioned, is important, especially at diagnosis, and you do have spirometry services within your PCN HQs. Some of the hospital and polyclinic spirometry services are open to GPs booking as well. And your vaccinations, influenza, pneumococcal, and COVID-19 vaccinations as recommended at that point of time. Again, I won't go too much into the data submission. I think this will be all available on the HSG care protocols. So I'm going to end off with a couple of slides. I think I've spoken quite a bit about the role of our PCN nurses. So beyond just advising, just helping to review the patient's asthma scores or providing teaching inhaler techniques, our nurses are great in terms of explaining pathophysiology, triggers associated with asthma and COPD. So for our patients who have perhaps poorly controlled conditions or newly diagnosed, do really consider getting our nurses involved in their care, and there's great value add that our nurses can do. Of course, our nurses also do emphasize the importance of a healthy lifestyle and help to advise on other preventive things such as smoking cessation, vaccination strategies. Just a little bit of additional things that our PCNs and PCN nurses can do. Of course, we know about the foot and eye screening for diabetic patients. I've spoken quite a bit about spirometry. So spirometry is available in some selected PCNs. If you're not sure, give your own PCN a call to find out about what's available there. And our PCN nurses also can help with a little bit of care coordination, right? In terms of referrals to the active aging centers or getting community care services for patients who need it, such as daycare, medical escorts, or meals on wheels, etc. My second last slide before I end. Okay, so just to rehash, do treat both asthma and COPD as chronic diseases. Give them regular follow-ups. Technique, always consider assessing the technique of your patients, especially if they're poorly controlled, or their conditions are not getting better despite increasing their medications. Tap on your nurses, and I do know that we've got GPs and polyclinic doctors here. You have access to nurses whether you're in a PCN or the polyclinic, so do rely on your nurses, and they have a great value add for our patients. Know your guidelines, and I think our local ACGs are a great resource. If you have a little bit more appetite, you can look at what GINA and GOLD have internationally. And remember your steps for asthma, step up treatment, and your ABCDs, and now it's the ABEs grouping of COPD management. And that's my last slide.